in our community. She went to Mary, and Mary said, well, let's gather together as a community. Let's answer as many questions as possible. As you know, our hospital is very much loved in the community and is very essential to our community. People have come to me and says, what's the Community Foundation doing about it? We're doing all we can to support the hospital and any organization that can make it better in our community. The format of tonight was done to make it as easy as possible to answer as many of your questions. Many of you sent questions in online. We have them. Some of them have already been forwarded to the panel. They will answer them, and others will be read aloud. We did not want tonight to be a session where people come up and give their opinions. Tonight is a night for us to get, hopefully, answers, to hear what's gone on for the last 3 or 4 months, and to have a direction of where the hospital is going in the future. So that's the purpose of tonight. People have been calling me for the last couple of days and said, Gary, I want to speak. I said, I know, totally understand. Maybe down the road there will be another forum in a different format that will allow you to speak. But this really was to answer your questions and as many as possible. So I'm going to invite our mayor, Mia Casey, to come up and do a welcome on behalf of all of us.
Oop, I'm going to tip it over. Good evening. Thank you all for coming. I know some of you may be thinking, what am I doing up here speaking? Because, you know, the hospital district is its own entity and not under the city's jurisdiction. That's very true. But the impacts from the hospital crisis affect all Hollister residents, and you are very much my concern. A few weeks ago, I found myself in Hazel Hawkins emergency room with acute bronchitis, unable to breathe, pulled muscles from coughing, and so very tired. My experience there was incredible. Everyone from the admitting staff to the doctors, nurses, x-ray, and respiratory techs were efficient and much like a well-oiled machine. But what struck me was not just how well they worked, but the caring and the kindness that they showed me. And it wasn't because they knew that I was the mayor and they were giving me special treatment, because they didn't find out until almost the end of my visit. But when they did find out, they spoke to me about their concerns about the hospital and also about their coworkers. Anyways, I walked out of that emergency room feeling so much better and on the road to recovery. And that's what I want for each of you, to be able to go to the hospital, get the care you need for yourself or your loved ones. And I don't want us to lose all of our talented hospital workers. My goal is to do everything I can to support this hospital and to ensure it doesn't close. I know that many of you out there are frustrated, angry, concerned, maybe even a little scared. You have a right to those feelings. I share them as well. But as Gary said, the purpose of this meeting, it's not really about venting anger or frustration. Tonight, the hospital wants to share information. So I would ask for all your cooperation in this regard. We're going to try to do as many questions as we can, get through them. Many of our elected supervisors and council members are here this evening. They're here to listen and learn as well what the latest developments are with the hospital. And they also want to hear from you and learn what the community has to say. I know that there's been a lot of criticism on how the hospital's been run, especially with regard to financial aspects. And I'm not here to dispute any of those claims. I'm sure there's been missteps, but there are 2 things that I really wanted to stress to you all. The first is the complexity of hospital finance is something that most of us will never really comprehend. I've been married for 20 years to a chief financial officer who works in the healthcare industry, and believe me, we've had many, many discussions about the difficulties around Medicare and Medi-Cal reimbursement and the trouble of working with private insurance. The fact is, you really cannot compare how a hospital operates to a school district or local government. There are some similarities, but you're really talking about apples and oranges. I don't consider myself an expert, but I can tell you it's extremely complex, and the hospital faces challenges that normal businesses just don't face, which brings me to my second point. What's happening at Hazel Hawkins, it's not unique. Small, independent rural hospitals have been facing a decline and going through financial crises for many years now. And the pandemic only made things worse. You can see it happening across our state and across the country. We only need to look at our nearby community of Madera, whose hospital closed just a few weeks ago. The panel tonight is here to speak to you about some of those big issues that have caused the crisis, also the steps they've been taking and will continue to take to improve finances and to find a solution to keep the doors open. What I can tell you is that there are success stories, hospitals that have come through a crisis and moved forward. Watsonville is an example of this. And do you know what I found these success stories had in common? Is the community, local government, and agencies worked together and rallied behind their hospital to support it. I said this when I was campaigning, and I firmly believe it, that the way we face our challenges and overcome them is by everyone working together, because we're stronger together. And as Gary mentioned, the housekeeping item for tonight is that we are accepting questions in writing. They're at the back. You can fill out a question and drop it here at the table, and we'll be reading them to try to get as many questions answered as possible. Thank you again for listening and participating, and I'm going to turn it back over to Gary.
Thank you. We're here tonight to listen to the experts, the people who have a deep love of our hospital. I've known Mary for a long, long time. I won't tell you how long. But here's a woman who has 27 years in the healthcare industry. And she always wondered when she'd come back to Hazel Hawkins. And 9 months ago, she came back, and she never thought she'd be sitting here as the interim CEO and in the middle of a crisis. So I'm going to pass it over to Mary and her team and leave it to you. I'll turn. I think the echo is because of that.
Okay, thank you, Gary. I just want to thank, first of all, the community for coming out tonight. Caring enough to come out and hear what we have to say is so important. So thank you all from the bottom of our hearts for coming here and caring. I want to thank Gary for agreeing to host and moderate for us tonight. And like Gary said, this is Mayor Casey's really brainchild. She called me. The hospital wanted to do something like this, and as you can imagine, we're really busy trying to do so many things right now. It was really hard to wrap our heads around it. But Mayor Casey said, you know what, I'll help. I'll help get it together. So thank you, Mayor. We really appreciate your collaboration. Supervisor Gonzalez also wanted to pitch in and help organize this, and she has as well. So thank you to Supervisor Gonzalez. And I want to thank our internal team led by Frankie in the back there for putting this all together. Thank you so much. Tonight we're going to do a short presentation and give you some information. Like Gary said, we did have some questions come in when we first originally had this scheduled a couple weeks ago. So we developed a presentation around some of those questions. And then we will have some come in today, and we're going to answer some of those, as well as take questions from you all. So we appreciate your interest, like I said. We are going to split the presentation up into 3 different areas. The first is all about the financials. How did we get here? Where are we now? That's going to be led by Mark Robinson, our CFO. Then I'm going to talk about the operations. What are we doing operationally to make changes in the hospital to move forward? And some of our plans about creating what we are calling a runway. Then we will bring up Barbara Vogelsang, who is our Chief Clinical Officer, who has the very difficult job tonight of explaining, if all of our efforts are not met, what it's going to look like to eventually shut the hospital down if we need to. Again, we haven't done that, but we want to be prepared, and we want to answer your questions around that as well. So I'm going to turn this over to Mark Robinson, who is our Chief Financial Officer, to start us off about finances.
Good evening, everyone. I am Mark Robinson, the Chief Financial Officer at the district. I've been a member of the community since February 2001, so I'm coming up on my 22nd anniversary with the district. I've been in healthcare 32 years, so I appreciate everyone coming tonight to listen to what we have to say. It is a trying period in the district's history. This is a multi-year problem. This goes back right before COVID. We're going to address tonight where we are currently. That's what you're hearing in the news. But it's not just one point in time. It's actually the last few years healthcare has been struggling, and we had some good and bad outcomes from COVID and the funding from COVID. So first off, the issue right now is cash flow. We're not taking in enough funding for the services we provide. That has to do with many things, but the key issue that happened, which is something we found out on June 30th, was Medicare sent us through the intermediary, which is a company called Noridian, information that they felt they had overpaid us for the prior year. So for July 1st, 2021 through June 30th of 2022, they estimated, their team, that they'd overpaid the district $5.2 million. Now, we actually file an annual cost report so that our consultants can say this is what we should have been paid. It's always a look back, but the intermediary doesn't wait for that. They actually do their own estimate looking forward. So what effect did that have on us? Actually, two, and it's in the minutes at our board meeting starting in July, is they started deducting funding from the district in July, starting on July 1st, to recoup the money they stated that they overpaid us for the previous year. In addition to that, they started paying less for the services we started to provide on July 1st. So in combination, it was a $900,000 swing, taking funding from the previous year and shorting us on funding from the current year. Added up, that's $900,000, and that happened immediately in July. Now, we have gone, and I'm working with them, and we filed the cost report, and I don't think it was that much of a overpayment, but that's something that will take months for them to settle with us. Another big, so $900,000 a month, about 20% of the Medicare payment is withheld from the district. Something else that happened last year, again, I mentioned we went back to 2020, so we went critical access March 26th of 2020. We did that not to lower the beds. We were only seeing for the previous 3 years, we were only seeing in the acute facility about 16 to 16 and a half patients per day in the acute facility. So it didn't make sense for us to continue that way because it wasn't making money. So we filed to go for critical access. We lowered the beds from 62 beds on a license to 25 beds on a license. But remember, we're only seeing 16 people a day on average. So overnight, that gave the reimbursement, increased the reimbursement to the district for approximately $6 million. So we're going to have less beds, see less people, but make more money. So how do we get to earn more money? This is a Medicare program, and they realize if you're a critical access hospital, you're normally rural. We just happen to be in a location between San Jose and Monterey, but they realize you need more funding to continue care. So they're basically going to pay us the cost of care. And again, we only from March 26th of 2020 through June 30th of 2020, they had a 3-month window that they could look at us and go through our expenses. So within 6 months, they informed us, we think we owe you another $3 million. So we just set that aside, that not believing they owed us more money. So our first full year of a cost report was actually the fiscal year 2021. That point, we settled up with the government, but that year was the biggest year for COVID because December of 2020 through February of 2021 is when COVID hit the first year, and we actually had a census in excess of 25 beds, at the highest 44 patients at the hospital. So we had a lot more costs associated with the care because people will remember, if you're nursing, we brought in a lot of travelers for that time period. So that inflated the cost of our care by about $6 million for the year. Now come forward into 2022, as they're going through the cost for the district, that amount of registry is not there anymore. So that is the reason behind the overpayment that we're working through. But in addition to that, changing the cash flow from Medicare, some other big changes were during the early years of COVID, the government was sending us money they expected that we would pay back. Some monies came free. You've heard of the CARES Act, or you've heard of ARP, American Rescue Plan. That's funding we have to reconcile with the government. But there was a fund called the Accelerated Payment Program for Medicare. So we didn't have funding in March. They sent us $6.9 million. That helped us through the tough time in 2020, but last year they expected that money back. So what they did, just like they're doing now, they just started taking the funding away from our claims. So money they lent us one year, they're reducing the reimbursement for the year we were working in. Another loan we took during that crisis time was from Blue Shield, $2.85 million. Again, the insurance plan, trying to be a good neighbor, lent us money, but last year we had to pay it back. And then also we participated in the FICA withhold. So for the year of 2021, we didn't pay the federal government our FICA taxes. So last year we paid them $1.14 million, and actually we still owe them another $1.14 million. So last year, we paid back $11 million in loans we had received from COVID. Other factors for that, during 2020, you may remember that we weren't doing elective procedures, right? So the state sent out a mandate, you couldn't do that. By not doing elective procedures, millions of dollars of revenue that could have been earned by the district was not. So for the year 2020, from operations, the districts had a shortfall of $9 million from operating, and the next year a shortfall of $4 million from not being able to operate, plus having the cost of the registry. So a lot of reasons we're not getting the funding we should, and then in addition to that, what's in the current year is we're experiencing inflation that hasn't been seen in 40 years. There's no way to predict that. When we do annual budgets, we have a certain amount of income we can raise, not through prices, but mainly through volume assumptions, because the federal government and the state government, 75% of our clients, they set the reimbursement rate. So regardless of what the district charges for a service, and regardless of what anyone else charge, the government, the federal government, and the state government still determines what you're going to be reimbursed for that service. Under critical access, at least Medicare counts our cost for that service. Under Medi-Cal, the state does not count the cost of that service in most areas. So a study from Kaufman Hall showed labor expenses since 2019 going up 16%, pharmaceutical costs 41%, and medical supply costs 19%. So double-digit inflation. In addition to the cost of providing care, the state also, if you will, legislates unfunded mandates. So they're telling hospitals, this is something you have to fund. Probably seismic compliance is the one you hear the most. We have to bring our buildings to code by 2030. In addition to that, there were some programs, unfunded mandates for COVID. So we had to start providing sick time to all of our employees because of COVID. Lastly, I'll mention, and this happens year after year for the funding, we provide millions of dollars of care for the underserved. So charity care, non-payment care, just because not everyone gets on Medi-Cal. There's a process to sign up. You have to be approved by the state. If you're not approved by their state, then you fall into what we call self-pay care. And in some areas, you don't get Medi-Cal coverage, but you can get charity care or relief for care. So that adds a couple of millions of dollars for the district. That's common in the industry for people to provide uncompensated care. Another story I just read, the American Hospital Association stated half the hospitals in the U.S. for 2022 ran on negative margins. So the negative margin, what is the revenue you generate from your business less the expenses? What's the percent that you actually get to keep? So when we say it's negative, you're not earning funding from your operations, you're actually losing money. So it's broad to talk about what's going on in the United States. Closer to home in California, the California Hospital Association, just for California, estimated California hospitals lost $12 billion. And that's after taking into consideration COVID funding. So the CARES Act funding and the American Rescue Plan funding was not enough to cover the losses many hospitals endured during that time period. Another question that comes up often is, well, maybe you're just in too much debt. You know, that's the problem. You borrow too much money. Actually, the last time we borrowed revenue bond money was 2013. And then in 2021, we refinanced that debt and saved $1.7 million. As we speak today, we owe approximately $10 million in revenue bond debt. We have over $60 million of equipment and property assets for the district. So we're not very leveraged. Many of you in your property tax, in 2005, we had Measure L. That was refinanced by the county in 2014. So that comes through the property tax. There's about $24 million of debt for that. It built the emergency room, it built the women's center, and it did some other things at the hospital. That debt is a pass-through for the district. It's paid by us, the property tax owners. Another small debt I did file for and we were approved early last year was a CHFFA loan for the roof. Many people have asked, you borrowed $2 million for the roof. Well, I did because that roof is 60 years old. The current hospital is older than the previous hospital. So from 1907 to 1962, on Monterey, the hospital operated. This hospital is older than the previous hospital and was in need of repairs. So the government helped us borrow $2 million for the roof. If you've experienced the rain for the last 3 weeks, I can tell you the old roof would not have made it. And as a guide for that, in 2019, we had 2 failures. We had one with ICU, the roof leaking, and then also the skilled nursing facility across the street with funding. So borrowing the money for the roof was a good thing to do. As of today, at least our net assets, we are over $20 million in net assets. So that takes into consideration any liability we may have. So I think we're pretty good financial position. Again, this comes back to the timing of when the state is going to pay us. A little update on what's happening. You'll remember, some of you came to the meeting November 4th. We had a special meeting, so the board passed a resolution that authorized the administrative team, if needed, to file for Chapter 9. At that point, with so much money going back into Medicare, I didn't think we could make it through December without some type of assistance. So the resolution came, and then it ended December 31st of 2022. So we've been working with the state, working with our elected officials, working with government entities, and Mary's going to mention some of this in a few minutes, on finding ways to bring revenue into the district. And it's revenue that we've earned. With Medicare and Medi-Cal, our large settlements are always a year look back. So we provided the service to the community. We're waiting to be paid for it. The bulk of the money, or a large chunk of the money, comes from what's called supplemental payments. So although I took care of that patient last year, I'm not getting the extra money for seeing that patient until this year. In December, the WARN Act went out. just like with the board resolution, we're following the law. We're informing people on schedule when we're supposed to. And when that act went out, we thought we would only have enough cash to February 18th, so the notice was sent. We've worked hard since February 18th to bring in more funding, and as of this month, as of January, we're now estimating that the Warren Act can be pushed out to April 1st because we're having more success with the funding we're receiving, and we're also taking some cost-cutting measures. So as of today, I can say we have not filed for Chapter 9. Some of the reasons we're trying to avoid that, the funding possibilities from the state. So we're in a situation where if we were going to file, the state doesn't want to give us money, and then if we don't file, the state will give us money. So we're working not to go into Chapter 9. There's also negative reactions you can have from suppliers. So although the board resolution expired on December 31st of 2022, some vendors are still treating us as if we did file. So we're looking to get relief because we didn't. The time and cost of bankruptcy, it would be timely and expensive, so we don't want to choose that route. Our bond debt is secure. As I mentioned, our debt is very small, but the property taxpayers pay for the general obligation bond, and Cal Mortgage, the state, secures the bonds. The $10 million in bonds is actually secured by the state. Why is that important? Because there's not room to really negotiate a smaller payment because the state is securing that debt. Another thing I'd like to bring up, we're looking forward to the benefits of staying out of bankruptcy, but that means we're going to go to mediation. We're going to talk to people, suppliers, unions, employees, everyone we can, because we want a solution that's not mandated to us or supervised. We want a solution that we come to as a team and settle on. I just want to remind everyone, when you say the district, the hospital, everything is under one license. So the district is the hospital, it is the 2 skilled nursing facilities, it's the 7 clinics, it's everything that we perform. It's all under one license. So when we're working to save the district, we're working to save everything together. Lastly, I was just on the phone today with someone at the state. We're actually working with them to pay us, again, $10 million we've already earned. We've already given care to our residents that fall under the Medi-Cal plan. So we're just asking the state, instead of making us wait till May or June for the funding, actually give us the fundings now when we need it. So anyway, it's a lot to cover. I will let you know the audit for 2022 is posted on our website, and I'm going to bring Mary up here to advance the discussion. Thank you.
Thanks, Mark. You heard Mark say that we operate on very thin margins in healthcare. That is across the United States, meaning it costs us, our expenses sometimes are more than what the revenue we bring in. The hospital's been experiencing that for quite some time. The board and administration have really come to understand that staying at independent hospital is really no longer an issue for us. We are committed to the community to continue the services for years to come. We need stability. We need a strategic plan to increase those services in the future. With the needs that we see for the community, there is no other option than for us to find a strategic partner for Hazel Hawkins and the community. We do have a plan in place to get us there. A major component of that plan is time. We need time. As Mark said, in November, we were looking at running out of cash in December. Then we extended it to February, and now we're looking at April 1st. We need more time than that to find a partner. So what is our plan? One of the questions that came in earlier when we were putting this together is, what is the plan to rescue Hazel Hawkins? What are the changes that are needed to take place? What is the plan to sustain Hazel in the future to avoid a situation like this? Are you hoping to be bought out by a partner or be in a partnership? The answer is yes, we are looking for that. And in order to do that, the first thing we need to do is secure emergency funding. We need funding to keep our hospital doors open for a longer period of time to give us the opportunity to find a strategic partner for Hazel Hawkins. We need to look at operational savings, and I'll be touching on that in a minute. That is part of our plan. We are looking to go into mediation with the unions, our debtors, our suppliers, and other stakeholders. And the last part of our plan is to engage an investment banker to help us find the right partner for our community. We are dedicated to finding the right solution for our community, and we are doing it a little bit different this time. The hospitals looked at partners in the past, but we decided to engage investment bankers to help us cast a wider net. We are not just knocking on the doors of our neighbor hospitals. We are looking across the United States to find a partner for Hazel Hawkins to make sure we get into the right partner and partnership. I do want to touch, because I know this is kind of an unusual thing, but what is a partnership going to bring us? That is a question we get all the time. In fact, I had a question come in, what's going to change going forward that would allow the hospital to be profitable? Is there a pro forma developed showing this? I do want to say it's difficult to develop a pro forma until we decide and find out what kind of partnership we're going to go into. There's many different partnerships that we can go into. But I want to focus on what would be the benefits of us having a strategic partner to move forward. First of all and foremost, preservation of patient access to care. That is huge. We want to make sure we keep the doors open, and a partnership will do this. But not only access to patient care and resources, but maybe new service lines. We would love to have a partnership that can bring service lines like cardiology, infusion care, dialysis to this community. A partnership can do that. We need to look at higher reimbursement. Mark touched on that. Higher reimbursement rates achieved through more favorable managed care contracts. San Benito County does not get the same reimbursement that Santa Clara or even Monterey County gets. Finding a partner will allow us to go into and have more leverage with managed care contracts. For instance, when we go in to negotiate with payers like at Blue Shield, Blue Cross, we don't have the leverage because we're not that big. So having a partner will give us the leverage to get better reimbursement. Having a partner is also economies of scale through group purchasing. Think about it. The more you buy, just like on Amazon, the more you buy, the cheaper it is. If we have a partner that's larger, we can take advantage of group purchasing. We can have improved productivity, enhanced bargaining power, and increased patient volumes. All of that a partner can bring us. Partner would also potentially, most likely, give us access to capital. Right now, we don't have buckets of money for improvements for the hospital. We're hoping a partner will bring us that. Lastly, a partner would give us access to infrastructure and technology in the form of billing, the electronic medical record, telehealth. Those are just a few things that an infrastructure can bring us when we work with a partner. These are all things that the community and the hospital would benefit from if we find the right partner. So that's one part of our strategy. To get us this, what we call a runway of time in order to find the partner, we need some emergency funding. We have gone to the County of San Benito with a proposal requesting an advancement in our property tax. The board did agree to give us a transfer of our April 2023 tax payment in December. So we did receive from the board 1.1 million. We should have gotten it in April. They gave that to us in December. We have also, last week, achieved a $3 million loan through CHFFA. Now, Mark told you we have very little loan debt, but we just received $3 million more from CHFFA to extend our runway. We are meeting with Cal Mortgage on financing options using under-leveraged assets. We are working with state legislators to request funding through the state. We have engaged the state treasurer's office. We have engaged and made a presentation to the governor's office. We continue to work with Assemblyman Rivas's office and Senator Ana Caballero's office and Senator Laird's office. We actually have standing meetings with them on a weekly basis. We are all working together to find emergency funding through the state. We continue to also look for private funding. We are not giving up. We are looking down every single avenue for funding to extend the runway that we can. In parallel to that, we are making some operational changes to save some of our expenses at the hospital. One thing we've done is implementing staff reductions through attrition. So when staff quit, we are not replacing those positions. We have also reduced a small number of positions at the hospital. We have also reduced high-price registry personnel, and that was really a leftover from COVID. We have reduced some professional services to save some money. We also have the exempt staff giving a deferral of their wage increases. And I'd like to say that the unions have followed suit and they have deferred their increases this year as well. Just those small chunks of efforts that I just talked about is saving the district over $2 million this fiscal year. We have very, very tight controls over our spending and cash management, which has resulted in net cash flow from the operations. Like Mark said, this is not a debt issue for the hospital. This is cash flow, money in compared to money going out. So we've really tightened the control of that. We also have an audit that we are conducting in our billing area. So we want to ensure that we are maximizing the revenue for the hospital and not leaving money on the table. One of the first areas that we've looked at is the clinics. So we are doing audits in those areas to increase the revenue. Again, that will help lengthen the runway. We have listed a surplus property for sale that is estimated at $2 million. We are renegotiating contracts with payers such as Anthem. That is generating an expected increase in cash flow starting in January of 2023. We are entering into an extended repayment plan with Medicare. Mark talked about the $5.2 million. When Medicare started taking that back from us July 1st, they originally scheduled to take that $5.2 million back in 11 months. Like Mark said, that payment, or the withholding of the Medicare payment, was over $450,000. We have been successful in negotiating that to extend it to 60 months, reducing that clawback to $60,000 a month instead of $450,000, which is huge for our cash flow. That's just starting right now in January. We are evaluating underperforming departments and looking at potential closure. We have decided to close home health services here at the hospital. That department was looking at losing $1.3 million this fiscal year. We made sure that those services are being offered by other agencies to our residents in San Benito County. There are 6 other agencies providing home health services, so we know we're not leaving the community high and dry on those services, but we will be saving over $1 million in wages and benefits from closing that department. We have implemented a hiring freeze. We have commenced the mediations, like I've said, with collective bargaining units and our debtors and suppliers. We have also had to develop whole or partial closure of the hospital in case all of this doesn't work, which Barbara's going to speak to in a minute. I just want to say this plan that we have is not immediate. We need the time. That's why we need the emergency funding. It can take up to 9 months or maybe even longer once we find a partner to get the deal done. It depends on what kind of deal we're talking about. So if we are not successful in finding a strategic partner or emergency funding, we will have to look at closing the hospital. And I'm going to bring up Barbara Vogelsang to let you know what that will look like.
Hi, I'm Barbara Vogelsang. I've been here with the district for about 16 months. I'm a registered nurse, and I've been a registered nurse for 35 years. I've been in healthcare and executive leadership positions for about 20 years. So when I came to Hollister last September, I came as an interim employee and expected to be here for about 90 days. And here I am 16 months later and knee-deep in trying to keep this hospital open for the community. However, in the event that all of the strategies that we're putting in place don't work, that we don't increase our cash flow, that we're not able to find a potential strategic partner, services that are provided by the district will need to cease. And we have to have a plan for that. We're required by the federal government as well as the state government to have a plan in place, and there are certain steps that we have to take in order to close something as important as a hospital. There is a 180-day requirement for a notice before the emergency department is to close. There's a 90-day notice before the hospital can close. There's a 60-day notice for the skilled nursing facilities and a 15-day notice for the home health agency. We have given notice for the home health agencies to close. Those will close on the 31st of January. The patients in those services have been and are being transitioned to other local agencies so that their care continues to be provided. We have not given notice of closure for any other entity in the district. And I think that's very important for everyone to hear, that we have not given notice for any closure of the district entities. If we do give that notice, the public will see this information on our website. We'll actually have signage hanging in the clinics and the hospital and other public areas. It'll be on social media, and it'll be very apparent exactly which services are going to close and the time that they will be closing. Currently, we have not given notice of closure for any of the services other than our home health agencies. We're required to have a plan and collaborate with the county services, the city services, the police, the fire, EMS. I know that everyone's familiar with what happened in Madeira. They thought they had a plan in place, they thought they had a partner, and at the very last minute that didn't happen, and they closed. They didn't get to give a 180-day notice that the emergency department was closing. And it has caused a lot of stress on the surrounding counties, huge stresses on EMS, as you all can imagine. So as much as we don't want to think about this plan, we do have to have a plan in place so that we're not kind of caught, unprepared. So we do have to have a plan, and we talk about it a lot. On one minute we're looking in one direction and talking about how we're going to stay open, but at some point we have to put, pen to paper and talk about what do we do if we're not successful in having a strategic partner and being able to stay open. So the plan that we talk about and what we will implement is we've broken it down into 3 different phases. And currently, we're in the midst of phase 1. As we've talked about already, we have given notice of a closure of our home health agency. That is a service that was continually losing money, and we didn't see any opportunity for it to be profitable and that the services are available elsewhere in the community. We'll continue to look at the services that the district has for continual loss and inability to be profitable. We're looking at the services that we provide out in the community that we also provide at the hospital that perhaps we can scale back with. In our clinics, we offer some of the same services that we offer at the hospital, so we'll take a look at the operating hours of those clinics and the different services that we provide as a measure of scaling back and still being able to continue to provide the services, but maybe at a fewer hours. We do have our 2 skilled nursing facilities, which we currently have over 90 patients and 90 residents. And our goal for the skilled nursing facilities, rather than a closure around those skilled nursing facilities, is if we have to move through this process, is that we would more likely lease or sell those services. None of us on this team have been able to even wrap our hands or our brains around displacing those residents. And so rather than not having those services available, we will look at other options that will allow the facilities to remain in the community, even if it means that we were to sell them or to lease them. So that's, like I said, we're in our kind of phase 1 of our 3-phase plan, looking at scaling back services and just evaluating everything that we do for our ability to be profitable. The second phase in scaling back services would include scaling back services that don't impact the hospital's licensure. So our hospital is licensed as a general acute care hospital. The hospital has to maintain 8 services, and there's nursing services, medical services, surgical services, anesthesiology, radiology, laboratory, dietary, and pharmacy services. So maintaining those services at the hospital would be, what our goal is prior to in the event of closing the hospital. So if there are those services out in the community, perhaps those may be, again, scaled back, but leaving intact those 8 essential services that make up the general acute care hospital. We would move in the direction of stopping elective surgeries in the latter portion of the second phase, looking at decreasing the number of beds that we staff in the hospital. We have 15 med-surg beds, we have 4 ICU beds, and 6 maternity care beds. We would look at scaling those back. And then, of course, prior to the need for actually closing the hospital and closing those services, we would have to, again, have given the notification to the proper, through the proper channels, and then begin transferring patients that would need care after a closure and redirecting patients that come through the emergency department to other facilities. So I just wanted to say again that in the event that we do not get emergency funding, that we're not able to find a strategic partner and be able to continue to provide services in the community, would be the only case, or would be the case when we would need to cease operations at the district. But again, we have not given notice, and we will continue to work on the strategies that have been discussed tonight so that we can continue to provide care for the patients and the members of this community. Thank you.
Now we move to the portion of your questions. I'm going to invite Mia to come up here in a moment, and she will go through the questions. I'm going to invite the panel to answer them from there, and you will decide who's going to say, and we'll get through as many as possible. We'll have 35 minutes for this, and hopefully we'll get lots of good answers.
So first, we got a couple of questions. Asking what the business plan is moving forward and the plan to get out of the financial crisis. I think you've actually kind of just gone over that, so I think we can...
Can I just
You want to add something?
Yeah, add
Sure.
something to that. So we have this immediate business plan, right, that I talked about. I do want to say we have also a master plan. It's kind of our dream, and we know what we need to extend the services in San Benito County. We've looked at that extensively as a team. We know how we can grow. We know which services would benefit the community, which services are missing from the community. That's still there. We still have that. Right now, we need to get out of this immediate crisis, and then we have another business plan to grow from there. But we don't have the capital, and we don't have the support right now. So we really have more than one business plan that I just thank you.
Okay. So what exactly is the difference between the original reimbursement agreement that resulted in HHH refusing to receive in-network compensation from Anthem Blue Cross and the one that was approved on December 28th? I think that's you, Mark?
We should talk about their compensation rates, as Anthem doesn't like to share it. I will say in general, of all the commercial agreements, they would have been on the end of not paying as much as some of the higher agreements. So that's why we went into the negotiation. We're glad we're back in the network, but as Mary had pointed out earlier, unlike Stanford, our larger chain facility, we just don't have the negotiating power of a larger entity. But we're happy they worked with us and we're back in our agreement, but it's still not where we would need to be.
Can you assure the public that fiscal changes are in place that would not result in the same fiscal crisis you're in should you find funding to continue operations?
Take that one. We are making every stride to, like I mentioned earlier, to do operational savings. Is there a 100% guarantee? There's not. Healthcare is very volatile, so we are making the fiscal changes that we can right now and ensuring we keep the services open, and like Barbara says, we're looking at reducing those as we go along. So do you think that answered?
Okay. Why has your board not considered resigning, minus new board member Devin Pack, due to the inability to fulfill their fiduciary duties to the community? Why should they be trusted in the future?
I'll answer that. I'm Jerry Hernandez, by the way. The Board of Directors has no plans of resigning. We are a governing board and give direction to administration. Our commitment to the community is to do everything we can to work with all the parties and stakeholders to provide health care. We have made changes when needed and will continue to work with the administration during this difficult time. We also agreed that the Hazel Hawkins can no longer stay independent and sustain services for years to come. We support and funding a strategic partner. We stand by all of our admin team, 100%. We have other board members here tonight that are showing their support, And I appreciate all the feedback that the community has, asked of us and has given us. And, we're going to be here in the long haul. We're not going anywhere. So, when my term is up, then we'll see. But for the meantime, I'm here to support all of you.
Okay. The county has done a great job of managing their own fiscal affairs and has a reserve for emergency situations. How do you justify asking them to give you their entire reserves when you have not shown your ability, nor have you presented a plan to gain public confidence?
I'll take that. So we went to the county in December for the advancement in our property tax. That was the amount we asked for, $10 million, was not their entire reserves. So we went asking for a portion of those reserves, again, an advancement in what they collect in the property tax as a secured repayment for them. But they did vote, like I said, to advance us the $1.1 million that we're due in April.
Okay. Do the doctors that are recruited and paid by Hazel Hawkins generate enough income for their salaries? Has anyone reviewed the professional component of the insurance contracts for the clinic docs?
I'll take that one again. First and foremost, the doctors are everything to us. If we do not have the doctors, we do not have Hazel Hawkins. So I want to stress that we would not have the services that we offer this community if we didn't have our physicians. So when we look at the physicians and bringing them on board at their contracts, we can't just look to the services that they provide at the clinics. We also look at the services that they provide. Remember, they're the ones ordering imaging tests, lab tests. They're the ones that doing surgery in our surgery center. So we look at everything as a whole. And we appreciate the doctors being partners with us and doing everything they can to keep the hospital open. That's one thing. The other thing was the billing. What?
Has anyone reviewed the professional component of the insurance contracts for the clinic doctors?
Yes, we have. When I mentioned the audit with the billing, that was the very first area we looked at, was the clinic. So yes, we are looking at that.
Okay. All right. If you had to narrow down the hospital's 3 major areas of concern, what would they be and why?
Finances. Finances. What else, Mark? Capital funding.
Capital funding. Yes, the cash flow, the capital funding. It's expensive to run the district, and as it ages, it costs a lot more money to repair the district and to upgrade the district. And just staying in compliance will just cost quite a bit of money, and we just don't have those capital reserves. And we're also at a situation where we're not going to have bankers looking to lend us money, because when they review where we're at, it's revenue into the future is what they're taking into consideration. So we need a partner.
Okay. What do you think the hospital does really well?
So, as I said earlier, I've only been here a short time, but one of the first things that I noticed that was very unique about this organization is truly the care that's provided. The folks are taking care of their neighbors and their own family members on a daily basis. And it just lends itself to a very, very different kind of care that you don't see in other places. So, it sounds like a canned answer to say, oh, they give good care, but they do give very good care. And some of the supplemental programs that you've heard Mary and Mark discuss tonight, that we've borrowed money from these supplemental payment programs, those payment programs and that supplemental funding exists because of programs that we take part in that are based on the quality of the care that we're provided. So the $3 million that we borrowed from CHFFA was $3 million that was basically awarded to us through a quality incentive program that is money that will be given to us at a later time, but it's based on a lot of measures that are monitored through the care that's provided in our clinics, through the care that's provided in our maternity unit, and throughout the hospital. So when I think of, we talk about borrowing this money, it's truly our money, and it comes from the fact that we give really good care.
Add something to that. In 2010, we joined an organization called the District Hospital Leadership Forum. It's an organization of acute healthcare districts. Our only purpose is to get funding for the hospitals, but for the Medi-Cal population. So in 2010, there were 45 acute care hospital districts working. Now there are 31 or 32. Also at that time, we were able to implement new programs, and we raised ourselves $30 million. Now we've raised over $330 million. It sounds like a lot, but for the inpatient care from Medi-Cal, the state has not given us a raise since 2012. So think about that. An entire decade has gone by, and we give raises and we have increases in supplies. We have so many factors we're dealing with, and the state has not added to their funding. So what happens with organizations we're working with, we're finding creative ways to get funding. So what happens is, in the past I've used the term an IGT, an intergovernmental transfer. We're literally in the biggest program, the Quality Assurance Fund tax. Hospitals are taxing themselves, sending this money to the state. Only the state can get a matching fund from CMS, from the federal government, and then that money is sent back to us. Basically, they also count the money they send back to us, what we put up, as a gift from them. So it's double counting what they're funding to the hospital, but we are doing this on our own. The programs that are provided by the state are nowhere near the supplemental funding that's provided from the hospitals who are participating in this state. And everyone has that, and at some point, and there have been articles with Korea Delta, how big they are. From July through September, they were losing almost $10 million a month. The main part of that reason was not in management, it's their population of Medi-Cal had grown, and it actually had grown in excess of 60%. So they provide great care, but if the state is not paying you to take care of that population, you're just going to lose more funding. So we try so many different things to keep the hospital going, but there are a lot of areas we're not getting that assistance we should, or the direct funding we should get on the front end from the state.
Okay, we kind of answered this one, but I'm going to read it in case you want to add anything. Is a sunset plan being developed or in existence for the current operations? What would be closed next, and so on? What about emergency room, clinics, lab, etc.?
That's pretty much what I answered with my presentation.
So nothing to add to that then?
Yeah.
Okay, good. All right. Is an outside consultant providing services to the Hazel Hawkins Board on financial advice and/or review? And if so, what consultant?
Yes, we are working with several consultants. The district is working with, the one I talked about, helping us find a partner is B. Riley. And they are experts in going out and helping hospitals find partners and strategic people to come in and either purchase, lease, do managed contracts. That's their business, that's what they do. So it's not just us with these efforts, but B. Riley is helping us do that. There also are financial advisors. So when I talk about having very tight controls of our finances right now, we have financial advisors looking at money coming in and money going out on a daily basis. We also have our legal team helping us through this process.
Okay. If solvency is not established for the continuation of the hospital as it is today, is the option that St. Louis Hospital arrived at several years ago one that is available, where hospital assets and programs were out to bid, with Santa Clara County being the respondent or winner of the bid, and subsequently taking over St. Louis Hospital?
I don't want to speak for the county, so that in St. Louis's solution, the county is the one who came in and basically took over, purchased the hospital. They had the winning bid, like the question said. So I don't want to speak for the county. I don't think we should.
Right. Could an effort be made to expand the number of insurance companies that view HHH as an in-network provider? We need more than just Anthem.
We do, and we're always open to new agreements, but they have to offer for their rates an acceptable amount to pay for the cost of care. Again, being a smaller hospital, and we just can't take someone who's not going to pay for the cost of care. Then you're not making any money by volume. You're just losing money when they come in through the door. So we're open to contracting with anyone that comes in with a reasonable amount, and we are not in a position to subsidize the profits of an insurance company. Anthem's not our only commercial agreement. We have Cigna, United, quite a few other agreements. We don't have Aetna, and that's something probably 6 or 7 years ago that agreement was terminated. My door is always open. I periodically reach out to Aetna, but again, it'll have to be an agreement to where both parties can win.
Can you possibly expand the number of services at the surrounding clinics? Thinking of the one at San Juan Bautista, possibly more income could be derived from additional service or patients who could use the clinics.
We are looking at all options. So it's important for us right now, if we're going to bring in a service, that we have a good return on investment. I'd like to see a business plan, a return on investment for that service. We can't just expand services. We do need some capital funds for some services, but yes, we are willing to expand. Right now we need to get through this financial crisis, and when we do look at a service, we will have a good ROI to make sure that we are not going to be losing money.
Okay. The Health Trust has some level of obligation to help support health for San Benito County. Did the hospital reach out to the Health Trust, and what response was received?
Health Trust,
It's the San Jose Health Trust.
Oh, is that what it is, San Jose Health Trust?
the Santa Clara County.
Yeah, they were a nonprofit, and they are meant to provide services in our county, yes.
In ours as well?
I haven't spoken to them,
Okay.
but we have spoken to health facilities in Santa Clara County.
Might be one to follow up on. Thank you. Janet? Does the hospital board of directors and management believe the future of the hospital is to be an independent organization that's not affiliated with a larger health system like Kaiser or Sutter?
You mentioned this, we're not seeing a way for us to stay independent and stable for years to come. Could we find some quick solutions maybe and get us another couple years potentially? But to stay sustainable, our goal is to do another 60 years. And we're not seeing a way to do that without a partner.
Okay. Other hospitals have received funding earmarks from the state, like Watsonville. Are we seeking similar support?
Yes, we are. We are. Again, we are working with legislators from the state treasurer's office, and we have a presentation in front of the governor. So we are looking for funding. Now, Watsonville was a different situation. We know that, and we've been told that. So we can't compare one hospital to another when we look at funding. We continue to work with them, be creative. We want to find a creative way and work together and collaborate, yes.
Okay. This one has 3 questions. The first is, why is the CFO still employed? Why has there not been a forensic accounting analysis of the hospital's finances for the last 10 years? And who actually owns the hospital at this time?
The district owns the hospital, and our finances are audited every single year. So you can go back for the last X amount of years, and there is an outside organization that takes a look at our finances. Our financial advisors even told us today how clean the books are and how well those reports are. So that is my answer.
This is a long one. Has anyone considered the impact to county residents that will be in need of urgent care? And if the hospital closes, they'll have to be sent via helicopter or ambulance to another county for care. Most residents don't have the resources for a $100,000 air ride for medical care. So we mentioned that when you did your closure meeting, but the cost and how that will be borne?
I think the question was, have we considered it? And yes, we consider it every day. We know what happens in that emergency department, and simply without that emergency department, it would be catastrophic. There are people's lives who are saved every day in that emergency department. So our efforts to do what we need to do and what we can do to keep the hospital in place are because we know what would happen if it wasn't there.
Okay. Do we know which departments generate more money for the hospital, which ones struggle to generate money?
We do. It's difficult, and Mary has talked about it before, because you can say one clinic may look like they're losing money, but they're also generating all the referrals for radiology, for the lab. So it's looked at overall. We did isolate home health, and that decision was made. I can say as we speak, now the skilled nursing facility actually makes more than the acute facility, and again, it has to do with the way that service is reimbursed, and also the volume that is taken care of in the facility. So as a whole, it's more expensive to run the acute departments than it is to run the outpatient departments. And you're always going to have support departments. Support departments don't generate revenue, but they function to serve the nursing and the ancillary departments.
All right. What's the viability of seeking a parcel tax from the voters of San Benito County?
We're looking at all options, and we are meeting with the county on that. So currently, our property tax market makes us about a little over $2 million. So about $2 million. And remember, we have a $150 million operating budget. So $2 million is what we get. We will look and work with the county, work with whomever we need to see if we can increase the parcel tax, but I do want to say, not sure that that's enough to every single year to get us out of what a certain year may bring us. Last year was different than this year. Again, healthcare is very volatile, so to put $1 amount on what it's going to take to make a solvent isn't going to be the same dollar amount what's going to make a solvent next year, because things change. So we absolutely will look at doing that, but we want to be good stewards of the community's money.
Are you currently in contract with potential partners or in negotiation to be purchased?
We are not in contract with, for a purchase. We have folks interested in us, and we do have folks signing NDAs, non-disclosures, so, which means that we can't talk about it. So, but again, this plan that we put in place, the strategy that we are using, so far so good, we are getting some interest.
And what purchasing restrictions, if any, have been imposed?
It depends on the deal. So not every deal is the same. I don't know if they're referring to Madera, because there are certain things when hospitals combine or merge, the Attorney General can get involved, and that's what happened in Madera. The Attorney General came in, put in some restrictions. So we are working with our legal team to make sure that we avoid anything that happened at Madera. Again, not 100% guarantee, but what our legal team is saying right now, because we are a district, that we may not have to go through that process that Madera did with the Attorney General. So we're hoping we have less restrictions in place.
Okay, and just one last question. What steps can the Board of Supervisors take that have not been taken already to keep the hospital open? You want me to answer that? Okay. So, you know, they have come a couple of times before the Board of Supervisors to ask for funding. I think at this point, part of the reason to share all this with you is, you know, they are your elected officials. And so what I would suggest is that you contact your elected officials, the council and the supervisors, to let them know what it is you want, because that will help them to decide what the next steps will be. All right? I think that's it.
Okay, let's go back one more step.
Okay.
Thank you, Mia. Thank you very much. Panel, thank you. You can imagine over the last 2 or 3 weeks when we started putting the word out that we're going to do a forum, everybody thought for some reason that I had the answers. And I got some incredible phone calls, incredible letters. I have a beautiful letter here from a patient who was born at the old Hazel Hawkins Hospital and has done a lot of services at the present one. And it's a glowing 3-page, glowing just about her deep love of the hospital. I'll end it with her last line in a moment. But on the other side of the coin, I also got some very angry and upset patients, as you can imagine. People who felt that they didn't get the care for themselves or their mother. And that is a hospital. If somebody doesn't come out alive, sometimes we blame our doctors, our nurses, and that will be every community hospital up and down the state. Your community foundation is part of a league called the California League of Community Foundations. There are 32 of us in California. And all over California, we're hearing these exact same issues, particularly in our rural communities, of them struggling to keep their hospitals open. And as you know, if a hospital does close, the possibility of it reopening is very, very slim. It's much harder to reopen something and start something from scratch. So I have to commend the board, the staff, and the community for your outreach. Look, we would normally, if this was a different type of forum, there's 150 people here tonight, you know, coming out on a cold night, by the way. You know, so thank you very much. I will give you a little smile for my last little comment. So this lady wrote this incredible deep love of the hospital, and this was her last line to me. She says, "If you don't fight for this hospital, you will be long considered as the man who failed this community." That's a heavy responsibility. Yeah, the man who failed this. And you know what I've learned is, working with the community for many years, no one person can save anything. We cannot. No one person. There's no savior coming in on a white knight. You know, it is us, the community. It's our elected officials here locally. It's our elected officials in Sacramento. And it's also our elected officials in Washington. They're the ones who are going to help. If we can't keep our rural hospital open, It's not good for anybody. So there is coffee, there is cookies, no calories, and you're welcome to come up and visit with the panel. Thank you all for coming. Thank CMAP and also BenitoLink. Thank you.